Good morning, good afternoon, good evening to all participants, depending on where you are. It's my distinct pleasure to introduce today's topic and today's speakers. I think this webinar is really well timed because earlier this year we heard from, we saw reports from WHO and UNICEF that the COVID pandemic had led to major backsliding for childhood vaccinations. In fact, they report in the WUNIC reports that 25 million children missed out on one or more doses of life-saving vaccines that's delivered through the routine immunization system in 2021 alone. This means that many of the world's most vulnerable children are left not fully protected from diseases like pneumonia, measles, pertussis, all the childhood vaccine preventable diseases. We are focusing today on pneumococcal conjugate vaccine because it is one of the most effective interventions for preventing pneumonia deaths among children under the age of 5. And countries have struggled to achieve universal coverage and to reach at-risk communities, but then COVID comes and knocks back all the progress that we've made. For this year's World Pneumonia Day, the International Vaccine Access Center at Johns Hopkins has gathered a diverse panel of experts to discuss what this means, what this immunization backsliding means for PCV coverage, and how can we come back from this backsliding to ensure that children everywhere have access to the vaccines that can save their lives. So it is my distinct pleasure to introduce our panelists, starting with Dr. Anik Sidibe, who is a technical advisor for JPIGO in Burkina Faso. Then we will move on to Dr. Ruth Lusinde, who is a research medical officer at Kemri Wellcome Trust in Kenya. And then we will also hear from Dr. Ruth Jimbo Sotomayor, who's a teacher and a principal investigator, Pontificia Universidad Católica in Ecuador. And last but not the least, we will hear from global experts who has been a pneumonia champion for several years now. We'll hear from Dr. Lulu Bravo, Professor Emeritus at University of Philippines, Manila. So without much ado, I would love to invite Dr. Anik Sidibe to kick us off with her presentation. Dr. Anik, over to you.
Thank you so much, Dr. Chizoba. It's my utmost pleasure to be here today to discuss and share a bit about the strategies Burkina Faso is using to increase pneumococcal conjugate vaccine coverage, but also to increase the vaccine effectiveness. Slide. And to do that, I want to present a bit my country, Burkina Faso, which is located in West Africa, in the heart of the West African regions. It is home to 22 million inhabitants. And unfortunately, since 2015, the country is experiencing security crisis, major security crisis that is growing. Also, political challenges with 2 coups that happened in 2022. And also, as all the other countries, the health crisis due to COVID-19 pandemics, the country experienced its first cases in March 2020. And we still have 21 active cases in the country. And with COVID-19 happening, the COVID-19 response, and particularly the immunization response, was as well quite challenging for the health system. Slide. That being said, as Dr. Chizoba mentioned, we know that pneumococcal conjugate vaccine is one of the most effective interventions to prevent pneumonia death among under 5 children. And WHO recommend to all countries to introduce pneumococcal conjugate vaccine, the 13 valence one, with a minimum of 3 doses. And in that recommendation, according to WHO, we can use either 3 primary doses without a booster doses, typically in the first years of life, or 2 primary doses with a booster doses around the end of the first year of life or within the second year of life. Burkina Faso, as many other developing countries, introduced pneumococcal conjugate vaccine in 2013 using the 3 primary doses schedule, because this schedule was better adjusted to our routine immunization calendar. And we introduced the vaccine at 2 months, 3 months, and 4 months of age. Since the introduction, vaccine coverage has been quite well, and it was around 100%. This is admin coverage given by the country. It was around 100% coverage since 2015 to 2020. But we recognize that since 2019, vaccine coverage has been reducing, and particularly in 2020 and 2021, where the country notified 66% vaccine coverage. Slide. So when we introduced PCV13 conjugate vaccine, we saw that in Burkina Faso, looking at meningitis due to pneumococcal conjugate serotype, we saw that the incidence of vaccine type meningitis decreased. But this reduction was significantly saw in under 1 children. But we saw that there were a persistence of the predominance of serotype 1, which is the main serotype present in meningitis in Burkina. And we saw that it was still happening, particularly for children after the second year of life. And in the country, the Ministry of Health was one of the questions that was happening, why this predominance of serotype 1, and was it because of the lack of herd immunity with the 3 primary doses schedule of PCV13 vaccine? And also we saw that there were growing evidence showing an improved immunogenicity and group protection with the PCV schedule using a booster doses. Because of that, Burkina Faso NITAG was requested to deeper dive into the evidence and to recommend to the Ministry of Health whether we should shift the vaccine schedule, PCV vaccine schedule or not. And following an extensive literature review, the country, and that literature review was done with also the technical advice of CDC Atlanta. The country decided, following NITAG recommendation, to switch PCV13 schedule. And to do that, the country received support from Gavi Switch Ground. Slide. And in June 2021, the PCV13 schedule has been shifted to 2 months, 4 months, and 9 months of age. So we introduced a booster doses at 9 months with the hope that this will extend, as saw in the literature review, the duration of protection of PCV13 vaccine, but also it will increase the herd effect, the group effect of the vaccine. Of course, to do that, there were many steps to take, like the revision of the tools, the M&E tools of routine immunization. Even the DHIS2 platform has been revised to take the new schedule into consideration. We have done cascade training of health workers, and also we have done a lot of supervision of health workers to ensure a smooth implementation. Having switched the PCV13 schedule, one of the things that the country is fearing is a drop of vaccine coverage, the third dose of vaccine coverage that was given at 4 months, but is now given at 9 months of age. So the country decided to closely monitor the third dose coverage, and the Ministry of Health, in collaboration with JAPIGO and CDC, to that effect, is implementing a 2-phase vaccine coverage survey. And by next year, we will know if this switch has reduced or not the third dose vaccine coverage. And also to assess the impact and inform the other country if whether they have to switch off or not, we are implementing in the country pneumococcal carriage assessment, both in community and at hospital level. And of course, we strengthen disease surveillance. Slide. So this was one of the interventions we did, as I said, to increase the effectiveness of the vaccine. Aside that, knowing that the country is experiencing security crisis, we also are implementing intervention to maintain the vaccine coverage. And I choose to speak about 2 of them slides. The first one is the task delegation, the immunization task delegation in security challenge areas. So this one brings community health workers, retired nurses, we train them and to be able to give the vaccine to the children in area where health facilities were closed because of the security issue. So I shared two results that were done this year in the district of Gorom and Seba. Those are 2 districts particularly affected by security issue with a lot of health facility closed. And we can see that for PCV 13, third dose here, highlighted on the slide, in both districts, Gorom were able to increase the vaccine coverage of at 21% using that strategy, and Seba more than more than 50% coverage were done through that task delegation. And this is for the district of Seba. We saw that around 4,000 children were vaccinated through the task delegation. Slide. So the second strategy is immunization campaign. The country, in particularly security, in area where there is a particularly security concern, we organize what we call multi-antigen catch-up days. And during those days, we do what we call the reconstitution of the vaccine calendar of the children. So we gather all the under 5 children together. We look at when they are available, we look at the vaccine card and the vaccine that have been missed, we give them. When the tool is not available, we use history, vaccination history, to kind of know where the children is in terms of vaccination, and we give him the vaccine that he is missing. We also developed a vaccination campaign for PCV 13 vaccine, mainly in Sahel region, because this is a region particularly affected by the conflict, but also by malnutrition. So we did a campaign around February and March of this year. And the campaign allowed us to reach 137,000 children aged 9 to 59 months. And this represents 99% of our initial target. And among those children, we saw that 53% didn't know their vaccine status. Slide. So this is just some picture slides on the multi-antigen campaign and the reconstitution of vaccine calendar. Slide. And thanks to those interventions, when I looked at the data, the administrative data on PCV 13 coverage in Burkina, we saw that things improved. From January to September, we are around 95% coverage globally at the national level. As in Sahel, which are in red, are regions particularly affected by the conflict, but the coverage has increased when we can compare to 2021 slides. So in conclusion, we can say that Burkina Faso shifted PCV 13 schedule to improve the vaccine duration of protection and herd effect, especially against serotype 1. And shifting PCV 13 schedule may lead to a drop in the third dose coverage. That's why we are closely monitoring the third dose coverage with support from the partners. And in particularly security impacted settings, we think that periodic immunization campaign could be an option to maintain and improve PCV immunization performance. The country is performing a cost effectiveness survey that will also inform the other country whether this is a good strategy or not. Thank you.
Thank you so much, Dr. Sidibe, for that excellent presentation. You will agree with me that some of the key things that came out from your presentation are that, number one, it's not enough to just introduce a vaccine. We have to monitor the impact of the vaccine, and that requires having strong surveillance systems. So kudos to Burkina Faso for having that in place. And then again, coverage is not enough, right? So you were able to look at the degree of protection, the duration of protection, and made a decision with your NITAG to have that switch. So monitoring the impact of vaccine, even after introduction, remains a critical part of the immunization program. So I would love to then move on to our next presenter, Dr. Ruth Lusinde from KEMRI. Dr. Ruth, over to you.
Thank you, Dr. Chizoba, and thank you, Dr. Sidibe, for setting the stage for my presentation. I'm glad that Dr. Chizoba, you brought up the issue of surveillance systems, because it's something I'll speak on in terms of our experience in Kilifi, Kenya, and how that has helped us monitor the impact of the vaccine in Kenya. So with my presentation, the first few slides will go through the impact of PCV introduction in Kenya. And then I'll speak about our experience during the COVID-19 pandemic, and then I'll close with a few recommendations and a few considerations for the future of PCV in Kenya. Next slide, please. So the Pneumococcal Conjugate vaccine was introduced to the National Infant Immunization Program in Kenya in 2011. And the vaccine that we've been using is Synflorix, a 10-valent PCV. The vaccine is given to children in Kenya at 6 weeks, 10 weeks, and 14 weeks. And so the schedule that we use is the 3 primary schedule. Early this year, we switched to the 10-valent PCV, Pneumococcal, and that's what we'll continue using for the next coming years. So very early on in 2010, 2009, when we had that the vaccine would be introduced to the country, I think we were very happy because we already had an existing surveillance system within the Kilifi County that gave us like a platform to evaluate the impact of the vaccine within the KHDSS. And so we have the Kilifi Health and Demographic Surveillance System, and then within it, there's a pneumococcal surveillance system that has been running since 1999. Next slide, please. So with the next slides, I'll briefly talk about this study where we evaluated the impact of the vaccine in Kilifi. And then this will lead to our experiences during the pandemic and some of the key things that we can think about for the future of PCV in Kenya. So PCVIS was conducted between 2010 and 2021 in Kenya. It was the first study to demonstrate the long-term impact of PCV10 in sub-Saharan Africa with no serotype replacement. And so this study evaluated the impact of PCV use in children on invasive pneumococcal disease of both vaccine and non-vaccine type for both immunization events and mortality events. And we've reported findings of this in terms of radiologically confirmed pneumonia, in terms of clinical, severe clinical pneumonia, so with or without hypoxemia, and also in terms of invasive pneumococcal disease. Additionally, this study explored the benefits of PCV in the context of cost effectiveness of the program, the impact on population immunity, and we've been doing this through carriage studies, the impact on circulating pneumonia in the population, and also the evolution of the molecular structure of the bacteria in Kilifi after the vaccine was introduced. So next slide, please. So the next 4 slides will just briefly outline what we've been able to show. And these are just some of the a few of the papers I could highlight that have reported our key findings. So the next slide, this busy table over here just summarizes the changes in the incidence of invasive pneumococcal disease before the vaccine was introduced. So this is between 1999 to 2020. During the early PCV era, between 2012 and 2016, and then much later, about 7 to 10 years later, that's between 2017 and 2019. And the important thing I'd want to mention at this point is that our study findings have shown similar results to studies done in other areas and reported, for example, the Gambia and Malawi. Next slide, please. Just next, yes. Another key thing we've been able to show, for example, is a 23% reduction in the incidence of clinical pneumonia that has been sustained through 2019. And I think the next slide would show about a 54% reduction or 53% reduction in the incidence of radiologically confirmed pneumonia. So PCV has been really, really impactful and has had a really good impact in our setting. So the next slide just displays the proportion of, the distribution of the serotypes causing invasive pneumococcal disease in Kilifi in the post-PCV period. The first bar would relate to Synflorix, the vaccine that we were using, and then the second bar relates to Pneumocil, which is the vaccine that we are using now. And as of 2019, 43% of invasive pneumococcal disease in our setting was caused by the serotypes included in Pneumocil. Next slide, please. Thank you. With this slide, now we can look at the coverage of PCV at 12 months amongst children resident within the county over the years. In 2012, just an year after, our coverage is at 85%. We've seen sustained increase in coverage. We had a dip in 2018, and could be due to a lot of factors, but one of the key things that happened in 2017 and maybe early 2018 was we had major healthcare worker strike. But as recent as 2021, coverage of PCV in Kilifi has been high at 93%. Next slide, please. So more relevant to our experience during the pandemic is what I'll talk about right now, and so we'll be on this slide for a while. Early on during the pandemic, we had a lot of reports of countries talking about lower coverage or fewer immunization visits because of disruptions related to the pandemic. And Dr. Chizoba, you had tried to mention this as you started. In Africa, countries like the Central African Republic, countries like Guinea, South Sudan, even Sierra Leone reported a decrease very early on during the pandemic in their immunization visits. And by mid to late 2020, they hadn't yet recovered their pre-pandemic coverage proportions. But in countries like Senegal and Rwanda and Eritrea, coverage of infant immunization wasn't affected by the pandemic. And this is also something we saw in Kenya. So I've highlighted just 3 studies that have tried to describe what we saw in our setting. The first one is the one on the top right. So this paper, which came out very early on during the pandemic, described the indirect effects of the pandemic on outpatient services and immunization visits. using administrative reports to the Ministry of Health. But on top of this, they also conducted key informant interviews with stakeholders at the ministry, healthcare workers at the county level, and even funders. And so in the background of disruptions to the global supply chain, to the health workforce, to the health infrastructure and service delivery, both internationally and in Kenya, this paper was able to show that immunization visits were not disrupted by the pandemic. Some of the key informants mentioned that financing for essential services, in which immunization services fall, was still maintained during the pandemic. And very early on during the pandemic, for example, health facilities were asked to map out the stock they have for existing vaccines, and if they needed some to cover them for the rest of the year, this was provided. This is before the country had a high case burden of case disease burden. So as a follow-up to that, we have the second paper on the bottom right, and this one tried to do the same thing using an interrupted time series, and they were able to show that disruptions due to the pandemic caused reduced outpatient visits, especially for children under 5 years. They disrupted follow-up ANC visits, specialty clinics, for example, HIV clinics, hypertension clinics, diabetes clinics. But lucky enough, immunization visits were not affected by these pandemic-related disruptions. And this was very, very encouraging to see. But more recently, and this is the paper on the left, we've been able to strengthen these results for these two papers by presenting the results of a retrospective cohort study that compared the timeliness of vaccination amongst infants and children who are eligible for vaccination before the pandemic, during the first year of pandemics in Kenya. So for example, between March 2020 to March 2021, and then during the second year of the pandemic, which would be March 2021 and after. And again, we were able to show that in as much as there are disruptions in other areas, immunization services weren't disrupted because timeliness of vaccination was maintained during the first 2 years of the pandemic. And for some vaccines like measles, coverage even increased while we were going on with the pandemic. So with my next slide, please. Maybe I'd just like to discuss a few future considerations that we have. We've recently switched to the 10-valent vaccine Pneumococcal. It would be very good for us to also try and evaluate the impact of this, try and see if there's any change in terms of serotype replacement, etc. And then there's also higher valency vaccines that may be brought into the country in the future. So things like PCV 15 and others. It would be good for us to continue using our existing systems and surveillance systems to evaluate the impact of this. Some countries have probably reduced those schedules, and we may find ourselves in such a situation in the future. It would be nice for us to have a platform or a system where we can evaluate the impact of these changes so that we maintain coverage of PCV as it is right now. There's also the effect, or the effectiveness of adult vaccination. So in Kenya, routine adult vaccination PCV is not in the routine practice. However, it has been shown to be helpful in some areas. So maybe this may be something we can consider for our region. Next slide, please. So just as I conclude, based on our experience within the Kilifi health demographic system, and also I guess the country, the importance of community-centered approaches in terms of improving and sustaining and maintaining coverage of PCV cannot be overstated. In Kilifi, we've had existing collaborations with the Ministry of Health, the county teams, community health workers, and even administrative workers in the county in terms of sensitization on the importance of vaccination, in terms of the importance of early detection when children get pneumonia, for example. So we are able to monitor these trends and also sustain the high coverage of the vaccine. So I guess an important thing for the future of PCV in Kenya is continued collaboration. And the collaboration could be in different ways. It could be through funding, so from some of our partners, to continue sustaining these surveillance systems that have been able to show such great impacts of the vaccine in our setting. But it could also be through, logistical support from the ministry team, could be by using existing structures like community health workers to empower them to continue promotion of the vaccine. And yeah, evaluating the impact of cost effectiveness of other adult vaccination in Kenya. I think the next slide is my final slide. Thank you.
Excellent. Thank you so much, Dr. Ruth. That was a fascinating presentation, and you just demonstrated the breadth and depth of research and data that's coming from Kilifi. I would say that Kilifi is one of the gems in Africa that has continued to provide solid evidence around the value of vaccine in different ways. Just to point out a couple of things that really resonated with me. First of all, you're able to demonstrate almost a quarter percentage reduction, almost a quarter reduction in clinical pneumonia from the surveillance sites in Kilifi. And again, almost a reduction by half in radiologically confirmed pneumonia as a result of using the PCV vaccines. These are the kinds of data that really strengthen the, our understanding of the value of vaccine and give credence to the continued investment in immunization programs. It was also interesting to me to note that you were able to switch your vaccines. We saw that in Burkina Faso, there was a switch in schedule. In Kenya, is a switch in vaccine just to respond to the, to the emerging data and to have better immunization programs. And then finally, I was intrigued to see that there was very little impact of the COVID outbreak on immunization coverage. I think that's a testament to the commitment and continued work of your team and others, within the Ministry of Health to maintain immunization programs for children. So I would like to then move over to the next presenter. That would be Dr. Ruth, another Dr. Ruth, Jimbo Sotomayor. Dr. Ruth, over to you, please.
Are you able to hear me?
Now we can.
Okay. Thank you, Dr. Chisova, and thanks for the opportunity to present today our experience about pneumococcal disease in Ecuador. I am going to present the case of Ecuador in terms of restoring coverage of pneumococcal conjugate vaccines has a priority. This presentation includes the following points. First, the objective, then a background about the health situation in Ecuador, an update of cases, mortality, and hospitalizations for pneumonia, the results of our studies on the clinical and economic impact for pneumonia in Ecuador, an update on vaccination coverage and strategies to restore it in Ecuador, and finally, conclusions. Next, please. The objective for this presentation is to analyze the consequence of reducing PCV coverage among the population in Ecuador and describe possible strategies to recover it and achieve effective coverage. Next, please. Okay, Ecuador is a country located in South America. There are 18 million people living in Ecuador. Of these, 600,000 are infants under 1 year old, and almost 2 million are children under 5 years old. The infant mortality rate is 11 per 1,000 live births in 2020. 85% of the Ecuadorian population use the public system for their healthcare. and 61% live in urban areas. And the most important, the immunization activities take place in the first level of care. Next, please. Okay, in this graph from the National Institute of Statistics and Census of Ecuador, it shows that pneumonia is an important case of burden disease in Ecuador. We can see that pneumonia and influenza are the third cause of death in infants under 1 year old, and the first cause of hospitalizations in children between 0 to 11 years old. This data was reported in 2019 in the pre-pandemic era. Next, please. Now, in this graph, we can see the trend of hospitalizations and deaths from pneumonia between 2015 to 2021. To collect this data for this graph, we use AC codes G12 to G18. It shows a reduction in mortality and morbidity in children under 5 years old from 2010, when the vaccine was introduced in regular vaccine scheme. It is notable that in the year 2020, there were less cases of pneumonia compared with the previous year. This reduction of case can be explained because many patients with pneumococcal pneumonia could have been classified as COVID. And for the public restrictions, such the use of masks or for the quarantine. Next, please. In Ecuador, PCV vaccine was introduced in 2010 and was changed to PCV10 in 2011 with a scheme 2+1, and then 2014 with a scheme 3+0, which is as until today. In this chart is the historical data of the pneumococcal vaccine coverage from 2010, when the vaccine was introduced, until 2019, when the pandemic began. The average coverage of pneumococcal vaccines was 84%. Next, please. In 2020, in collaboration with the Ministry of Health in Ecuador, Pan American Health Organization, and Yale University, we estimate the impact of pneumococcal vaccine on pneumonia in hospitalizations and mortality in children and elderly in Ecuador. In this study, we demonstrate 4 important points. Number 1, a reduction in hospitalizations of 27% in infants under 1 year and 33% in children under 5 years. Second, a mortality decline, a reduction of 14% in infants under 1 year and 10% in children under 5 years. There was also a reduction in mortality in adults between 50 to 64 years of 22%. And there was no evidence of reduction in mortality in adults older 65 years. Next, please. In this last year, we worked in great collaboration with the International Vaccine Access Centers of Hopkins University. In the study, we estimate the return on investment from PCV vaccine in Ecuador. From this introduction in 2010, an estimation until the year 2030. The results of this study demonstrate that the total economic benefits of PCV in Ecuador exceed the immunization program cost after the introduction there. Next, please. And now I want to talk about what happened since the beginning of the pandemic. In Ecuador, several health activities were interrupted because of the pandemic. The vaccination activities were not the exception and were also suspended. In the table, shows a reduction in vaccination coverage to 62%. For this value, it was taken into account the third doses of pneumococcal vaccine. you can see the reduce of coverage of vaccination. And this percentage is a risk factor for the development of the invasive cases of pneumococcal infection, such as meningitis or bacteremia. Next, please. We are working now in a study to analyze the reasons for non-vaccination in children in the first level of care centers in Ecuador during the pandemic. We found out that the main reasons for non-vaccination could be classified in 3 groups. First, the group of the parents or caregivers. The main reason were the fear of getting infected of COVID during the pandemic, and there was also a lack of public transportation during this period. The second group is the health workers or prescriptors. Because of the pandemic, many workers were relocated in hospitals because of the scarcity of the professionals, leaving the primary care settings without professionals. And the 3 important topic is related to the healthcare system. Because of the pandemic, many resources were focused or assigned to treat patients with COVID and by COVID vaccines. And as a consequence, other vaccines could not be obtained for the primary care attention. Next, please. Okay, now I am going to analyze the possible strategies to recover coverage of pneumococcal vaccines in Ecuador. It includes 2 massive campaigns with the objective to increase the coverage of the national immunization scheme in children under 5 years and children with an incomplete vaccine status. The campaigns include the following points. The vaccine supply was guaranteed in all vaccination places. This is very important in Ecuador. Has a communication campaign was introduced in all communication media. For these campaigns, the support of famous athletes was used with the message such as every champion gets vaccinated. A positive reinforcement from society members such as athletes has positive impact, especially in parents and caregivers. And finally, an animated character called Maximo was used in this widely recognized animated character that had a big impact in previous vaccination campaign 27 years ago in Miss Lee's campaign. Next, please. Okay, and in this map, you can see several provinces of Ecuador has reached better coverage of vaccination, but other remote places has not reached an adequate levels of coverage yet. This result correspond to June 2020. Next, please. And so, in conclusion, Ecuador reported a decline or delay in vaccination related to COVID pandemic. In Ecuador, the PCV vaccines has demonstrated positive effects in disease prevention and economic benefits. It is mandatory to recover vaccine coverage to prevent the burden disease increase and the appearance of previously controlled illness, and sustainable catch-up programs are recommended. And finally, NJ's vaccine ability is crucial to recovery vaccine coverage. Next, please. Okay, thank you for your attention.
Thank you so much, Dr. Ruth, for that excellent presentation. You've heard it from her. There's a different experience where COVID pandemic had an impact on immunization. So let's move really quickly now to the next presenter. We will have a little bit of time for Q&A at the end. So please type your questions in the Q&A box so we can get to them. So Dr. Bravo, over to you.
Thank you, Dr. Chisova, and thank you very much for Dr. Anik and the 2 Ruths that we have for really covering their country's strategies. Now I'm going after a different type of, not my country, but a regional approach. Next slide, please. You know, in 2011 to 2020, the Global Vaccine Action Plan was promulgated by WHO, that was endorsed by 194 member states to strengthen routine immunization and accelerate the control of vaccine preventable diseases, introducing the new vaccines. And actually, next slide, please. We did have in the ASEAN region the possibility of really going after pneumonia, because it has been shown to be somehow a forgotten killer of children, with 2 million children dying, you know, less than 5 every year, and 1 out of 5 deaths was due to pneumonia, where the specific pathogen was number 1, was strep pneumo, the leading cause, with the others having the Hib, the H influenza type B, and other viral diseases. But it was strep pneumonia that needs to be addressed. Next slide. And so in this region, in 2007, even before that GVAP, that Global Action Plan, there was a regional approach, and we have the ASEAN countries to come together to contain and control pneumococcal disease in this region. And we established what we lovingly says ASAP, and it represents 4 important aspects, the context of which will be awareness of the pneumococcal disease, surveillance, advocacy, and prevention. To us, this ASAP is still existing, and through the years have been strengthened by many pediatric leaders in the Asian region. Next slide. The objective of this ASAP mission, which was established, as I said, in 2007 at the International Vaccine Institute, was really to collate and disseminate available data on disease epidemiology within the region, create that awareness about pneumococcal disease and its prevention among professionals and the public. And last but not least was to communicate and engage with policymakers regarding the importance of pneumococcal disease and its prevention. Next slide. We know, of course, that these are the challenges, but we knew that immunization would be the key driver of sustainable development, enabling other priorities like education, economic development to take hold. We believe in immunization. We believe that vaccines could be key contributors to global reduction of under 5 mortality. And this has been going on since the 2000. Next slide. Ladies and gentlemen, we wanted vaccine confidence, but we also knew that it cannot be increased by facts and education alone. Yes, there were challenges, but there were also barriers in the way that vaccine confidence, even in the ASEAN region, even in, I guess, African and Latin American countries, can be increased. Next slide. So what did we have to look at? We look around us. In the Philippines, for example, which is actually having the highest rate of vaccine hesitancy nowadays. It was not like that before. Way back in the 90s and the early 2000s, the Philippines, from which I come from, had the highest vaccine confidence. We had a health minister who gave a much value on making sure that children get their immunization. We had a very high vaccine coverage, up to 90% of our children in the 90s. But through the years, as you all know, complacency, convenience, confidence, what WHO said are the 3 key barriers to vaccine coverage has been going on. And even in terms of disasters, when vaccine coverage would go down, mothers would not be able to let their children come to the clinic. But most of all, we started to feel some misinformation. In the early 2000s, at the turn of the millennium, we realized there are ongoing misinformation that vaccine side effects are now being feared. And then came the COVID, which actually exposed the vulnerabilities of our information system. And next slide, please. What is happening throughout the world is something that we really are so worried about, because children are not being given the appropriate vaccine. The immunization coverage, not only in the Philippines, but in many countries, have started to go down. And there were serious problems. COVID exposed those vulnerabilities. We remember that most of them are now afraid. And that was what Dr. Ruth from Ecuador said, that mothers are afraid of the side effects. Next slide. So what we have now is to really make sure that the restoration of PCV, in order to extend this longevity, and of course, make sure that children are given the appropriate vaccines to save their lives. The awareness and appreciation of the value must be known by policymakers, health authorities, funding agencies, industry, researchers, civic-oriented groups, economists, and health workers. This is the only way that we can get to an effective networking and partnership to achieve our goals. Next slide. So we do need to come up with campaigns. And I am so glad that even in Africa and Ecuador, we do have to do some form of campaigning, some form of educating the masses, some form of communicating that prevention is the key to reducing deaths in children, and that PCV, knowing that pneumonia is the #1 killer of our children, will be addressed. Next slide. And we cannot just do it on our own. We have to engage policymakers. We have to do it in a way that will also be acceptable socially and culturally. We cannot do just lecturing, and we cannot just tell them that this is good for you. No, we also have, next slide, we also have to do it in a way that is acceptable to the people. You are able to let them see that you are passionate in the way that you work with the children. So do your vaccinations. Next slide. Do the things that you need to do, even doing it in a form of dance and song. You know, in the last global forum, we had a nice placard saying "Stop Pneumonia Deaths." That was so wonderful, because even people will appreciate the fact that our health workers will dance or will come up with something that is culturally acceptable in order to engage the mothers, the policymakers, to work for stopping pneumonia. Next slide. And so the indicators for our success is to have a good way of delivering all those vaccines, from pre-implementation activities, identifying where the areas need to get their vaccine, where are the risk areas, where should be the people who need to be there, and of course, looking at this type of administration. There are many processes, but we have to work together, because in the long run, next slide, in the long run, ladies and gentlemen, our duty as healthcare workers is always to educate the masses. Thank you very much.
Thank you, Professor Bravo. That was excellent as usual. I always love to hear you speak, because your passion for pneumonia advocacy comes through. There's no doubt about it. So we do have a couple of minutes left for questions and answer. And I see there is one in the chat from Leaf. So I'm going to read it. And perhaps Dr. Bravo or any other person can take this. It's been 22 years since PCV became available, but still half of the world's children are not protected. And about 50 countries, including Gavi eligible countries, have not introduced PCV at all. Why is uptake so slow? Why is price still too high? Do we need global health agencies to offer more support to LMICs? Are LMIC governments not aware of the power and the life-saving ability of these vaccines? So that's a loaded question. So Dr. Bravo, I don't know if you want to start chipping away at it. Thank you.
You know, it has really been questioned by many, the equity. We need the low-income group to get the vaccine foremost. But sometimes it's the rich countries who get them, right? And even now, I remember we did go to the advanced market commitment so that the African countries and low-income countries can get the vaccine. We need to work together. We need to demand it. And if we do, we can help each other, support each other, because equity is the #1 important aspect. But we have to work together. I think that can happen. In the Philippines, we have the vaccines, but what is the problem now is the vaccine hesitancy, as I said. In fact, the supply is there, and you may have it, but somehow people do not get it because they're not aware that they can demand it, that they can get it, that it's just there, sitting on the corner. So you have to educate them.
So you're saying in countries where the vaccines have already been introduced, we need to do more to educate the people, not just to tell them about the vaccine and where to get it, but to show them in interesting ways how to get it. Okay, thank you. Thank you very much for that. Let's see if we have another question. So in that light, what are some of the most important steps to expand outreach services to underserved areas to reach missed children? Maybe I can take this to Dr. Ruth from Ecuador.
Okay, thank you for the question. I think there are several steps to improve vaccination, especially in underserved areas. In Ecuador, there are many problems in these sites. I want to point out 3 strategies. First, vaccine accessibility. Countries must guarantee an adequate supply of vaccines and also adequate supply for the remote areas. Second, the prevent of missed vaccine opportunities. This is an important topic. All children must have a vaccination register in each visit, and it should be mandatory for every children in the country. And finally, for me, it's important the communication strategies for sensibilize to the parents, to the caregivers about the importance of the vaccination and to give incentives to these people for get the vaccinate.
Okay, so again, education to parents. And Dr. Bravo, you showed a picture about dancing, maybe a TikTok video on PCV vaccination might work. Okay, so I'm going to throw the last question to Dr. Ruth from KEMRI. There's a question from Professor Matthew Santosham that says, does KEMRI have data on serotype coverage with SII vaccines versus Synflorix?
Thanks. So we currently don't have data on that. We just started using the Pneumococcal vaccine late in July. So that's a few months ago. Hopefully, in the next coming months or in the next coming years, we'll be able to compare both of them. Thanks.
Okay, but your switch was predicated on what? Wasn't it on better serotype coverage?
Yes. So I think, and if you could go through the slides, we still had a lot of invasive pneumococcal disease being caused by serotypes that are covered by the Pneumococcal vaccine. And so we hope that now introducing it would have pneumonia caused by those serotypes.
Okay.
Yes.
All right, thank you. I think like I said, we have one last question. The last question should be to, I guess I can ask Dr. Sidibe to cover this. How do we combat misinformation?
Yes, thank you. That's a good one. And I think Dr. Ruth and also Dr. Lulu spoke about it extensively. Misinformation is one of the leading burden for immunization. And particularly since COVID-19 pandemic and vaccinations raised a lot of social media misinformation spread. So one of the way we use in Burkina Faso to fight against misinformation is to use communities. We use community leaders to spread the message, because we saw with COVID-19 that political leaders, even sometimes scientific leaders, are not trusted as much as it was prior the pandemics. So our strategy is to convince, to sensitize the leaders, the community leaders, who still have the attention and who still are listened by the communities, and they are the one now spreading the message on immunization. And that's been proven effective both for routine immunization, but also for COVID-19 vaccination in the country.
Yeah, that really resonates with me. We've seen from many studies that we really have to expand the partnerships within immunization, because there are other influential people in the community that can help with addressing misinformation and driving vaccine acceptance. So I'm afraid that we have come to the end of the webinar, and perhaps I would like to ask Dr. Lulu to, give us one last comment before we bring this to a close.
Yeah, Chisoba, 1 hour is not enough for World Pneumonia Day. Actually, if I'd like to greet Leith and Dr. Maturam, who are really very close to my heart, because they have been inspiring me to do this pneumonia days even before. See, cost is not really the biggest problem here. To me, if you were to really look at people working to make sure that countries have the vaccines that they need, it's all up to us to really demand it and give it to the people. That has been happening in Africa. In fact, Africa had even an earlier introduction of PCV than in Asia or Latin America, if you notice that. They had the earlier introduction. It is the awareness, it is the demand, it is the way that we work together. And in the Asian region, I can tell you the Philippines had also been one of the earliest, including Pakistan. Pakistan was the earliest in Asian region to introduce PCV. And then we followed. And there was Singapore. But it is not just the price, as I said. It is really an important factor that we realize. We make our policy makers aware of the importance, the value of vaccination. Vaccines do not save lives, it's vaccination, and the policy makers must know that. We have to educate them. So that is an important issue that we have to talk about. Even for misinformation, you have to work to neutralize those anti-vaxxers and to communicate with them in such a way that you will be able to not really to sort of challenge them, but really to convince them that there is a way for you to become heroes, vaccine heroes, and become champions of vaccination. That's my message, Chisoba.
Thank you. Thank you so much. I couldn't say it better. So I want to thank all the panelists for an excellent job. To the participants for staying and hanging in, and of course to the organizers for inviting me and for bringing us this excellent panel. So please, as you go back, remember, the work is not over yet. We still need to introduce a PCV in 50 countries. Even in countries that have introduced, COVID has led a backsliding. We need to, recover the gains, and we need to continue educating parents and pushing our policymakers to bring the vaccines to all the children that need them. Thank you very much and have a wonderful rest of the week.